Great, thank you. I'll try and live up to that very generous introduction, and thank you to you and to everyone else for joining in today. I hope today is useful. We're going to think a little bit outside the box today, so not at the normal ear conditions which I normally talk to you about, but I want to give you an idea of how broad the problem is when we see our patients with balance disorders. Now, if I can move on. Oh, that's interesting. There we are. Health warning. Okay, just to start with. I'm going to talk about a lot of symptoms today. It does not mean you have that condition, because one of the problems with balanced medicine is it's very different to lots of other types of medicine. So in some types of medicine, you might have a very simple symptom. You've fallen over, you've got a twisted arm and a lot of pain, and you've broken your arm, and that's nice and straightforward. In balanced medicine, you might have one symptom, dizziness, but there may be a whole host of different causes of that. And indeed, you may have lots of different conditions running at the same time. So that's really, really common. And that's the theme I'm going to try and show you today, that as a doctor looking after you with a balance disorder, dizziness, I have to look at a whole range of different potential conditions. And in fact, we have to aim to treat each of those that are in fact treatable. So please do not lose any sleep over what I'm going to tell you today. So we're going to run through a lot of different things. What you'll see from this talk is it's quite information heavy. So there's a lot of different conditions I'm going to talk about, some of them with very long names because doctors like things with very long names. And again, they're not there to try and blind you with science. And I'm not trying to explain each condition in any great detail, but I'm just trying to give you broad themes of how we think as doctors, or we should think as doctors, when we're seeing our patients with imbalance. So you can see here a whole range of different conditions, from things that are natural through to things in the brain and the nerves and the heart and the body and just about everywhere else. And everything I show you today, I will have seen in clinic over the 20 years that I've been in Leicester. So here's something I've shown you before as a group, and Andrew Hugill is someone who'll be familiar to the group and is a professor of computers in Leicester. And we put together this thing called the balance disorder spectrum, and it's got lots and lots of different words on it. And again, it's not to show you individual diagnoses, but to give you the idea that there are lots of different conditions that might cause your symptoms. And you can actually Google this. If you Google Andrew's name and if you Google my name and then balance disorder spectrum, you can look this up on the internet. And if you click on one of these diagnoses, ototoxicity, which was, I see, was one of the questions, I think, from later on this afternoon, and a whole range of other things, we've filled in some very, very simple bits. We haven't annotated it in great detail, but the idea of it is just to give you an idea of the different types of conditions, but also how different symptoms make us think about different diagnoses. So if you look down at the bottom, the conditions in blue, we would think of as vertigo sensation, so an abnormal sensation of movement, an hallucination of movement. And the darker the color, if it's dark blue, it's 1 in 100, and then as it gets lighter, it gets rarer and rarer. And then the yellow one down here is disequilibrium. So that's a sensation of being off balance or unsteady when you're walking, which is different to a spinning sensation. And it has a different range of potential causes. And then there's lightheadedness. I feel I'm going to faint, doctor, or I'm going to pass out. And that's a whole different range, not necessarily at all related to the ear, but sometimes it can be. And it might be more often related to the blood system or the heart. So that's a very simple way that we start thinking about vertigo, disequilibrium, and lightheadedness. And you'll find when you see your doctor that we try and probe these very gently with questions, and we really try and concentrate on how your dizziness started and then the symptoms you have as they evolve. So we have lots of techniques in trying to pick these out. So let's start with some common examples. And actually, I think these first few slides are really helpful because they'll really help you understand what's going on in your brain when you're dizzy, whether or not it's an ear-related problem. So we use some long words, and forgive me for them, but we use the term etiology, which is what's the cause of the dizziness. And this first group of conditions we're going to call physiological. Now, physiology is how your body works. So it's how a normal, healthy body works. But the healthy body can still cause symptoms of dizziness. So dizziness can be a normal protective sensation, stop you getting into a situation where you may put yourself at harm. And the black and white picture here, you and I, not in a million years would we put ourselves in that situation. I mean, he's crazy, whoever's doing it. But actually, it leads to this concept of height vertigo, which is really common. And it may result from a couple of different causes. So if you see a soldier standing on guard and they look like they're absolutely rigid, they're actually not. What they're doing is they're rocking back very slowly like this. You can't see it, and they're not aware of that motion. But what's happening is they're focusing on an object in front of them without knowing it, so subconsciously. And as they move backwards and forwards, that image moves across the back of their eye, across their retina. And that motion gives the brain a sensation of depth and position. So that's one of the contributors to allowing them to stand up upright without falling over. Now, if I were upside down on a plank 800 feet above the Manhattan road, it would not just be that vision that was causing me problems. I would be terrified. So anxiety also plays a part in dizziness, and we'll see that in the next examples. So here's a good example. This was in May of this year. Now, I had the great honor of becoming president of the otology section, the ear surgeons of the Royal Society of Medicine this year. And it's one of the biggest honors that we can be given as an ear surgeon, and we're voted in by our fellow consultants from around the country. And we also have the privilege of running many lecture courses on dizziness and ears at the Royal Society of Medicine, which is a grand building in the centre of London, and going on tour. So we lectured to around 500 doctors around the UK, trying to spread the word, spread the message. And we're allowed to invite an overseas speaker. And this is a professor from America in the middle here with the red trainers on, who we took on tour. Now, on tour, we went to all the countries of the UK, and we started in Wales. So this is West Wales. What we didn't realize is this professor of balance medicine from America, who's one of the most famous professors in the world, to preserve his dignity, I won't mention his name, but he stays with me every year on my balance course that I run in Leicester. We didn't realize he was so scared of heights. And he's needing 3 of us here to walk him over a cliff top in Wales. So anxiety is a really common cause of dizziness in certain situations. The brain is taking over some of the balance function. And I'll come back to that again in a minute in a way that I hope is really helpful in understanding what's going on. And here's me last week. So I was in Italy last week. Now, one of the small perks of the job is we do have meetings in interesting places. So this was the Path of the Gods, which is on the Amalfi Coast, south of Naples. And you'll see, before you walk on the Path of the Gods, not only does it say, take your time, it says, be careful of falling. And if you've got dizziness, maybe this isn't the right thing for you to do. And my wife is quite scared of heights, it's fair to say, but she just about made it. So this is a common theme. And look, this is me taking a picture of my colleagues walking along. Just watch them walking along the Path of the Gods. Isn't it beautiful, by the way? Now, what you'll see is 2 of them walk to the left. This is the most famous professor of noses in the UK. This is a surgeon who takes out tumours from people's brains who've got dizziness. And this is my colleague who led the Meniere's intratympanic injection studies. You remember, if you've had Meniere's disease and you've had steroids or gentamicin injected, this surgeon here was the lead. And this very, very lucky chap here has just retired as an ENT surgeon. But just have a look at them walking along, because you've got a vertical cliff ahead of you, and just to the left here, you've got a vertical cliff. Now you'll see me hovering and sticking to the right. Do you see that? And you'll see 2 of them slightly cautiously going on the path, the high road to the right, and a couple diving down to the left. These 2 surgeons here have got no visual dominance in their balance. That cliff on the left there is 100 meters or more vertical drop, and it would absolutely terrify me. But the two on the right are sticking as close to the right-hand side as they can to try and avoid that scenario. So it's a really
can you come and listen to this, Maria?
It's a really common scenario.
Can you come and sit and listen to this? Or you've got to go out and do something?
I'm going to go and have a med.
I just ask you to.
Oh, right, okay.
I can pick it up later, all right?
Yes, okay.
Could you just mute Alan Sample's phone? Could you? Sorry, hello. Could you mute that?
Hello, sorry.
No problem. Thanks. And over on the right, this is the picture after the walk. It poured down with rain, but we've got the most magnificent rainbow afterwards. It is beautiful out there. Okay, so let's have another physiological one, a body one. So we're all familiar with seasickness. Now, I think that this is a really good way of understanding how the body works. So if you're on the back of a boat, let's imagine, I'm going to put my thumbs in front of me, and that boat is rocking backwards and forwards, and you're looking at the floor of the boat. The distance between my thumbs and my eyes, or the floor of the boat and my eyes, isn't changing. So my eyes are telling my brain I'm not moving, but my ears are telling my brain I am moving. So we've got a conflict of sensory information from our ears and our eyes to our brain. That gives us seasickness, dizziness. And that conflict of sensory information from the eyes and your ears is one of the principal causes of balance and why we do lots of the exercises we give you. So what do you do on a boat when you feel seasick? You look at the horizon and you fix on the horizon. So when you're rocking backwards and forwards, your eyes and your ears are telling the brain the same sensation. And the same can occur also with somatosensory input, that's touch. Again, we'll come to that a little bit later on. So how does that morph into the real world? How might that help us? Well, one of the first things I tell my patients or ask my patients is, are you wearing varifocal glasses? Because if you've got varifocal glasses and you're dizzy, your ear is going to be sending incorrect messages about your position in space to your brain, but so is your eye because of the varifocal glasses. So if you have migraine or you have this visual dominance imbalance, don't wear varifocal glasses, just get some cheap reading and distance glasses to start with. And that may be a really simple way to help start your recovery from balance problems. Okay, so let's think about some psychological factors. There's no question that emotion, anxiety, depression are all strongly in play when you have a dizzy disorder for many people. And for some people, it's the primary disorder, and we have to identify that and try and correct it if that is the case. And for many other people, it is a secondary disorder. In other words, they develop a dizzy condition, whatever that condition is, and that causes anxiety. And then a whole host of things occur. Maybe they're anxious going outside because they're fearful of falling, or they're fearful of people thinking they look drunk. How horrible to have people thinking you look drunk. So they stay at home and don't go out. And if they're staying at home sitting on the settee, your muscles atrophy, your muscles shrink. And this is the term we call deconditioning. So then you get into this vicious cycle of worse balance over time. And one of the common things we see is hyperventilation. So if you feel dizzy, you get palpitations, maybe you get tingling in your fingers and your lips, you feel really anxious and lightheaded, it might be a simple hyperventilation anxiety problem. Now, there are some balance conditions, and there's a condition called vestibular paroxysmia, where hyperventilation triggers impulses in the nerve from the ear to the brain. But these are the sort of things that I would have to tease out from you when I see you in clinic. And of course, there are also chronic anxiety disorders and panic disorders, which can be strongly associated with chronic balance conditions. And we use lots of different techniques, whether it's from self-help books, hypnotherapy, psychologists, medicines, and a whole range of things to try and address that if we need to. Now, this is where I'm going to touch on persistent postural perceptual dizziness, PPPD. So it's very commonly discussed in clinic. It's amazingly only very recently described. About 2016 was the first major paper on it. And what it does is it brings together a whole range of other conditions, visual vertigo, chronic subjective dizziness, phobic positional dizziness. There's a lot of different terms we had. Now remember, it's not a diagnosis like a broken bone or appendicitis. It's a term used to describe a set of symptoms. So that's a different way of thinking about medicine. But it's not directly an ear problem. It's a brain problem. It's a central processing disorder of the brain. In other words, the brain is handling sensory information from your eyes, from your ears, from your joints incorrectly. And there are many common triggers to this condition. It might be an ear disorder, BPPD, head injury causing weakness of ear function, vestibular neuritis, all these common causes in the right person can go on to produce this later on. And it's commoner in our patients who have migraine, and it's commoner in our patients who have anxiety. And many of you will have migraine. So 4 out of 10 of my patients in the Balance Clinic have a history of migraine. And you'll know that one simple way of describing migraine is the irritable brain. Now, I often say to migraineurs, you're advanced human beings because you're much more sensitive to the outside world and climate change and lots of other things. And that may have been very helpful millennia ago, but in the chaotic world that we live in now, where we get sensory overload, actually migraine is pretty tough. And so if you're that sensitive, sensory changes internally from balance disorders can be much more distressing. And it's a common disorder. And what do our patients with triple PD feel like? Well, they describe a wide range of different symptoms. I feel like I'm on a boat or I'm moving, so a non-spinning vertigo. I feel I'll fall, I feel unsteady. But you see how that symptom also overlaps with disequilibrium, this imbalance which might be caused by joints and muscle weakness. I feel lightheaded, or I might faint. Well, I said to you earlier that that might be related to a cardiovascular, a heart or blood pressure issue, so there's overlap. I feel dissociated. I'm not with the world. Maybe when I move, the world lags behind me, or I just don't feel with it. And that, of course, can overlap with anxiety. People are worse when they're upright, so it's a postural dizziness, in motion, or if they're surrounded by motion. So we used to sort of call it supermarket vertigo. It might be worse in crowds or with patterned floors or scrolling on your phone or computer. So these are all typical symptoms of triple PD because the brain isn't handling the sensory input very well. And you get this visual hypersensitivity, so just motion, computers, all this stuff around you, it's all just too much. But we see that in migraine as well. So I think the theme I'm trying to give you here is that with many balance conditions, there's not one key. The symptoms overlap between different conditions. And that's why we need lots of bits of information to try and get your diagnosis. And I use this analogy in clinic of a jigsaw. So when you come in to see me, I talk to you, I get lots of bits of information, I'll put into my jigsaw, I'll examine you, I'll get tests, maybe scans, and then each bit of information builds the picture. And you have to put all those bits of the jigsaw together to try and get the diagnosis. Now, I like this concept of a central processing, a brain processing disorder of balance. And we've done quite a lot of research which shows that the way our patients with triple PD handle risk is different to patients without triple PD. In fact, you could almost predict it. And my son, who's over there, did a very nice research project which we've published using a card trick. And if you use this card game, which has got risk involved in it, you can predict who's most likely to get triple PD from how they manage in the card game. So the triple PD patients have a greater sort of skew of risk in the way they answer the questions, and they adopt a high risk strategy in the card game when they don't need to. So in a way, if you have triple PD, you don't have any choice. You're pre-programmed to have it in response to what your brain has developed like. So here's another really interesting way of thinking about balance. And I think this is really, really helpful. So if you're someone who is fearful of falling, feels really unsteady when you're walking and it's really unpleasant, this little description here, I hope will be really helpful for you. Now, I suspect most of us recognize this famous picture from the 1930s in New York. It's a real picture. And these workers, brave workers, are having their lunch 820 feet above the Manhattan street line. Now, they look pretty chilled. Of course, it was a staged photo, but they look pretty chilled. If you or I were there, we'd be absolutely terrified. Now, again, why is that? Well, we discussed in one of the first slides about this visual dominance. So if they look between the skyscrapers in the distance, there's no movement across their retina because they're all an infinite distance away. But there's also this anxiety. I mean, I would be terrified I was going to fall to my death if I was up there, and quite rightly too. They seem to have learned not to be terrified in that situation. So they're processing balance information differently. But what happens to our patients, and actually me as well, if we're in an environment like that, when we fear we're going to fall, is something quite profound in the brain. So when we walk along normally, we just wander along, turning our heads and walking along the road, not thinking about our balance. And the primitive part of the brain, at the base of our brain, has lots of reflexes which maintain our balance whilst we chat and shop or whatever else we do. But if you have a balance disorder and you're feeling unsteady and you're fearful of falling, as you would be, or most of us, if we were on a beam like that, what happens is the front of your brain, which is the conscious part of your brain, takes over your balance function. So suddenly you're putting one foot carefully in front of the other. You hunch a little bit, you stiffen up, you get really tense, and you really concentrate. Just come out of that. And that's actually a fundamental problem, because by doing that, you've developed a fear of falling. And here's the thing. If you use the conscious part of your brain, it's much slower at responding to changes in sensory stimulation than the reflex part of your brain at the back. So paradoxically, you're actually less steady. So that's a really fundamental problem in our patients who have a chronic balance disorder. And that's something we try to address with medicines, which reduce that sensitivity, and with physiotherapies and psychological supports. And that's why those are the three main treatments for persistent postural perceptual dizziness. And I think that's a really helpful construct, and I hope that was useful. Now, what I want to do now is, I'm not trying to blind you with science. This isn't a test for an exam, and all of the diagnoses I'm going to put through in themselves are not important. But what I want to do is, I just want to run through the range of potential conditions that I'll be looking for when I see someone in clinic, because very often these have been missed, because very often patients who come in with chronic imbalance have not got better because there's more than one thing that's going on. So one of the potential things causing unsteadiness is peripheral neuropathy. And it's absolutely astonishing how many people have it. So 1 in 20 people over the age of 70 have lost sensation to some degree in their feet. That's a really big number, isn't it? And there are lots of causes of it. Diabetes, alcohol, autoimmune diseases, vitamin deficiencies, lots of different things that we can test for and are important, because if that's the case, we need to think about managing you in a different way. And there's another slightly stranger type of neuropathy, and that's nerves that run from your brain to the rest of your body, neuropathy not working. And diabetes is the commonest, and it can cause you to drop your blood pressure when you stand up, and a whole range of other symptoms. Now, there are some syndromes that we learn about, and this one the medical students love, because they all learned in medical school that patients with this condition have inverted champagne bottle legs. That's something medical students like to remember. So the top of the legs are quite broad, but the bottom of the legs are narrow. And patients with this condition have flawed toes and high arched feet here. So you'll often see, if you have symptoms that might be compatible with this, that I'll ask you to take your socks off. I'll run my hands down your legs over your feet. And patients with this, I'll listen to you often coming into clinic, because I can hear a slapping way that people walk with this. They may not have any reflexes when we do the tendon hammer. may have lost sensation in the feet. So this is called Charcot-Marie-Tooth, and it affects about 1 in 2,500 people. That's not very dissimilar to how many people have Meniere's disease, for example. So if any of you do pub trivia quizzes, here's your fact for the day. So if you have a rare condition, by definition, you're pretty unlucky to have that condition, because in the UK, a rare condition affects 1 in 2,000 people or less. So this condition here would be a good example. So what are you going to say to your doctor? The first thing you're going to say is, why me, doctor? Well, the simple answer is that there are so many rare conditions that about 7% of the population have a rare condition. So that's about 1 in 11 or 1 in 12 of the population have a rare condition. So actually, we need to look for those, because there's a whole number out there that might be contributing to symptoms, which in themselves are very rare, but as an aggregate, with all the different conditions, aren't rare at all. So let's move on from the sensation in the legs and the periphery to the brain. Have a look at this person walking. Now, if you look at this person walking, you can see they're just doing little steps. Yeah, little steps like this. Now, I watch you coming into clinic. I watch carefully how you walk, and that gives me a really good idea of what the problem might be. And that is called marche à petits pas. So those of you who can remember your school French will remember that it's a walk of small steps. Now, in fact, in this particular case, this individual was walking upright like this. Now, in Parkinson's disease, which you've probably heard of, patients walk stooped and forward. Looks the same with the feet. But in marche à petits pas, our patients walk upright. And in fact, if I scratch their toes, there we are. If you just watch the big toe, this is called a plantar response. Watch the big toe and it moves up. Okay, so if the big toe moves up when we scratch the foot, it's likely to be a brain problem. And if it moves down, it's less likely to be a brain problem. So there are reasons that for many of my patients, I'll scratch the toes during the assessment. And in this particular patient, this was caused by little white dots on the brain. You can see a white dot here and round about in the middle of the brain. And that actually is just an aging process. It's not a particularly specific diagnosis. But you can see that in a lot of other conditions, occasionally Parkinson's disease, multiple sclerosis, and other things. So that's just one of a huge range of conditions that arise from the brain that can cause imbalance. And I put a list down here, and we're going to talk, I'm not going to talk about migraine today because that's a whole hour's talk on its own. But there's a whole range of other conditions which can contribute. And again, I'm running through these, A, not to put any fear in you, please remember that. B, not to make you think about a specific diagnosis, but just to show awareness or cell awareness that there are a whole range of different conditions that occur. Now, one that we quite often talk about is Chiari malformation. And this is a side-on view of the brain. This is the cerebellum, which is the balance part of the brain. I hope my arrow is showing up on here. I'm not sure if it is. Kevin, can you nod? Can you see my arrow moving around the screen? Yeah, great. Okay, so this is the tongue here. The nose is going to be over here, eyes here, and this is the main part of the brain. This is the spinal cord. But what you see here is the cerebellum, little tongue, has slipped down into the neck. It's actually not that uncommon. Now, why this is relevant is that our patients with this condition get headaches when they cough. When I drop the head over the end of the bed on the Hallpike test, the eyes beat downwards. But most particularly, patients get dizziness when they extend their neck back. So we have lots of patients referred in with this condition who actually have BPPV, which is those crystals in the inner ear. So people are becoming more aware that this is a fairly uncommon condition, but we do pick it up and it needs to be diagnosed. Now, one of the things we're really anxious about as doctors is to make sure our patients haven't had a stroke. So very many, if not most people, will end up having an MRI scan. And this is something I really teach very firmly to the doctors when I give lectures of this type. And there's two dizzy strokes that we see most particularly. Well, the first is pica stroke, which is posterior inferior cerebellar artery. And it's a blood vessel at the back of the brain. And this is the commonest of the dizzy strokes. The thing is that when you get this type of stroke, you'll be very unsteady all over the place. You get dysarthria, so the speech becomes uncoordinated. And that type of stroke is usually very easy to recognize as a stroke, and will go to the stroke doctors. And certainly in Leicester, we have the most magnificent stroke team. It's a real iconic national service. And if you get into the stroke team, you'll be amazingly well and very quickly looked after. The type of stroke we worry about more is the ICA stroke, the anterior inferior cerebellar artery. And it's a blood vessel that comes up the spine, the vertebral artery meets into the basilar artery. And then as that goes through, it gives a branch to the anterior inferior cerebellar artery, and then a little branch from that into the inner ear. So if a bit of rubbish flows around your blood, it goes up here, along here, across there, and by really bad luck goes down into your inner ear directly, that can cause labyrinthitis. But if it bleeds from this vessel here, it can cause a stroke, i.e. a brain thing that needs treating as a stroke. But the symptoms may not be brain things because it supplies that blood vessel to the ear. So you may lose your hearing, you may get vertigo, you may even get BPPD as a consequence on it. So just because your presentation is loss of hearing and dizziness and weakness of inner ear function doesn't mean the primary problem is in the ear. It might be in the brain. So that's the reason that I look very carefully, and my colleagues will look very carefully to see if there's a brain cause of an ear-related problem, and it's because of the nature of the blood supply. Here's another one called vertebral insufficiency. This is another one where if you look up, you get dizzy. And this was something that we used to get referred very, very regularly. But actually, it's another one of these blood supply problems. So you'll probably have problems with your speech, vision, drop attacks, and so on related to this. And it's much commoner in our older patients who have got other blood vessel disease like angina and so on, although we do see it occasionally in other conditions, such as following whiplash injury. It's a difficult diagnosis, this one, but it's one we look out for. So there's blood supply problems as well. One of the conditions that our patients are really worried about very often when they come with dizziness is multiple sclerosis, MS. And it's not such a rare condition. And about 1 in 5 people with MS will develop dizziness at some stage. And 1 in 20 of our patients with MS present with dizziness. So here's another challenge for us. In our patients with multiple sclerosis, and indeed with many of the neurological conditions that I'm talking to you about today, when they develop the full-blown condition after months or years, it's very easy to make the diagnosis because all the clinical signs are there. But in the first months, or first year or so, perhaps, the symptoms can be very subtle. They can be, I am just a bit unsteady and dizzy, and there's no other symptoms. So they will come to people like me in an ENT balance clinic. And the clinical signs I look for can be very subtle indeed. And it can take months or years for the full-blown condition to make itself evident. So do you see how, as an ENT surgeon in a balance clinic, it's actually very challenging sometimes. And I'll often say to my patients, well, look, I think this is what's going on because we've got features of this, but I can't be certain. And we'll have to use that additional diagnostic tool. And that additional tool is time, because we have to wait and see how a condition evolves. But with multiple sclerosis, we have a whole range of different things that we can find, which is why I tap the reflexes and scratch the toe and do all of those other fancy tests. And in multiple sclerosis, we get lots of white patches around the brain. We can even see infections. Here's tuberculosis. You see the infection spreading all around the edge of the brain here. Very rare in the UK, but recognized. And here's another very common condition that I pick up very regularly in the balance clinic, and that's Parkinson's disease, which we'll all be aware of. And that's when people begin to look what we call a flat affect, like that. Hunch forward, writing gets really scrawly, get a bit of a tremor, walk with a shuffling gait. well, surely these type of conditions are rare. Not at all. 1 in 100 of us will have this over the age of 70. It's a really big number, isn't it? Say Leicestershire with a population of 1 million, 10,000 people in Leicestershire are going to get Parkinson's disease sometime in their life. Now, very early on, it can present just with a sensation of slight unsteadiness, and it can be very, very difficult to pick up the diagnosis, although I'll often say to my patients, well, there's a possibility some of your symptoms and signs relate to Parkinson's disease, but I can't be sure. And I may need to get a neurology opinion and DAT scans and other things. So there's lots of things we look for to try and find that diagnosis. So that's why we need a lot of time to assess you. And then there's a range of other conditions which are rare, thankfully, but I mean are sadly really quite unpleasant, and most commonly occur in, I'm going to call it middle age, in the 50s and 60s, and present with loss of balance and falls. And there's a number of other conditions which occur with them. So progressive supranuclear palsy, PSP, multi-system atrophy, MSA. These are rare conditions. They are unpleasant conditions, and they're progressive conditions. And they can be really difficult to diagnose very early on. And they need specialist neurology input later on. So just to give you an idea that there is a whole world of different diagnoses out there. And there are some ataxias that a number of my patients have. And if you're watching, I haven't looked through everyone who's watching yet. I will do in a minute. I know some of you have these conditions, particularly the idiopathic late onset cerebral ataxia. It's got a different name now, but it affects about 1 in 10,000 people. And it's typically in 50s and 60s, a very slow, progressive worsening of balance. And we need to carefully assess for that in clinic as well. And then there are some really rare conditions, again, always think about. So episodic ataxia type 2 is one of them. And that's a genetic condition where you get intermittent spins, which is very much like migraine and Meniere's in its presentation, but it's a calcium gene. And the weird thing is that same gene codes for one type of migraine as well, called hemiplegic migraine. So there's a big overlap. Oh, I've written it on there, the CACNA1A gene, a calcium gene up there, and we can now test for that. And then just to sort of sum up the neurology bits, there are some conditions which are really important for us. And in our younger patients, idiopathic intracranial hypertension. So it's usually young, overweight women experience this, and they get a raised pressure in their head. Now, for our ENT surgeons, one of the things that they really need to look out for is one of the markers of this condition is pulsatile tinnitus, so a pulsing sound in the ear, along with poor coordination. And that's really important to diagnose. And at the other end of the age spectrum is normal pressure hydrocephalus, which is another buildup of pressure in the head. But the way our patients with this walk, it's like this, often with a walking frame, stomping on the ground as if they have magnets on their feet. And they may have poor memory and urinary incontinence. And that's very common in elderly care homes. And it causes progressive symptoms. So there's a range of these conditions we do look for. Then epilepsy is one that people think about really frequently. And actually, it's incredibly rare. I've just had a handful of patients with epilepsy causing intermittent dizziness. And it's usually a temporal lobe epilepsy. And the syndrome we call is an Alice in Wonderland syndrome. And people feel like they're being sucked down a plug hole, for example. And that's how they describe their dizziness. So you can get quick spins with epilepsy, but it's pretty uncommon. And then there are head injuries and strokes. And we need to think very carefully. Do you see, this individual here is, I'm not going to give his story in detail because it will give away who he is, but that's blood. All that white area is blood on the brain. And this patient came to me with a story that he'd had a very minor bump on his head. And his wife said, oh, he's just not himself. I can't. And I said, well, why have you come to see me? His balance isn't perfect. And he said, oh, I'm fine, doctor. I just had the minor bump. But we are going on holiday, and we have the holiday of a lifetime in a couple of weeks. And we've saved all our lives to do this. And I couldn't find much going on, but I just thought, they're going to be flying halfway around the world. And he's just not right. So I got a scan. Thankfully, I got a scan. And we found his brain was full of blood like that. And it saved his life, because if he'd flown, he would have been in very, very big trouble. And we treated it, and he did get on holiday a year or two later and phoned me up a year later to let me know. That was a really very, very special special story. So he's a very special memory of mine to think what a difference we made to his life. So there are things that we do look for, and that for those who want the medical diagnosis there, that's called a subdural hematoma. Now, we'll ask you, so that was a pretty heavy section of the talk, I appreciate, but I want you just to understand that there are lots of complicated brain and nerve conditions I have to look for to make sure they're not present. I have to look carefully at what medicines you're taking, and one of the ones we bang on about all the time is Stemetil, prochlorperazine. It's a great drug in the short term if you're dizzy. Do not take it long term. Firstly, because it stops adaptation, it stops your balance getting better. And secondly, it can produce Parkinson's symptoms with shakes. So that's not one to have on regular repeat prescription. So let's have another look at someone walking. Have a think about this patient. Now, they're really wobbly, aren't they? And what might be the cause of this person's walking? Slightly different to the other short stepping the gait that we saw in the last patient. But this patient, if you have a look, is, do you see how they're having to really throw their legs forward, and it's really difficult for them? Well, this individual has bilateral knee replacements, but also has a peripheral neuropathy. So they've lost sensation in their feet, and they can't place their feet in space. And a lot of patients I see will have multiple joint replacement, hips and knees and various other things. And then on top of that, might have a peripheral neuropathy, and on top of that, might have a problem with the ear balance as well. So lots of different things going on. And then there's the heart, and we're going to whiz through the last bit now, because I know there's lots of questions you want. But we have to think about the heart as well. And there's lots of different types of heart problems which can contribute. And the symptoms of this tend to be lightheadedness, fainting, palpitations, pallor and sweating, and better when lying down. We have to take a careful history. And this is tilt table testing, if anyone's had it. Because I do it to my patients sometimes, I did have it done. It's not terribly nice, actually. And it's not done by ENT, it's done by cardiologists, it's done by the heart doctors. And you have to stand up for a long time, and they try and make you faint, which is, it's not a whole bunch of fun. But it leads on to diagnoses of syncopes, and syncope means fainting. And there are lots of different types of faint. Just to make it even more difficult, sometimes just standing up, like the soldier who passes out because all the blood's pooled in his legs, coughing, passing water, micturition sympathy, syncope, carotid sinus syncope. So I've seen this on people. I've done the drop back on the bed to test their BPPV, and they pass out because I stretch the pressure receptors in the neck. Amazing stories that we've seen. Blood pressure being dropped. So it's orthostatic hypertension. That's dropping blood pressure when you're standing. Sounds straightforward. Goodness me, look, huge host of different particular causes of that. Cardiac sympathy, syncope, irregular heartbeats, problems with the heart or medication, and structural diseases. So narrowing of the blood vessels in the heart or masses in the heart. So you see, there's a whole host of different heart problems as well. What is it everyone worries about when they come? Have I got a brain tumor, doctor? That's at the back of everyone's mind. We will get a scan to look for it, but thankfully, it's actually very, very rare to have a tumor as a cause of dizziness, although we will always look to try and find that. And if they're very small, they're more likely to present with spinning, and if they're large, they tend to present with imbalance. Your hormones can be wrong. You could be anemic, diabetes, your thyroid could be wrong. You could have pituitary disorders. I'll just give you an example of this. This is such an amazing and powerful story. So my father-in-law is a Booth. So his grandfather founded the Salvation Army, William Booth, and he's a missionary, and he's a great preacher, and he's preached all around the world. And he is a force of life. In his early 80s, he was up one of our trees, made the fairly fundamental mistake with the chainsaw sawing the wrong side, the tree branch, when he was trying to chop it off, managed to fall off. But that's the sort of person he was. He then started getting dizzy and lightheaded. He then started falling over, broke his nose falling over, and he couldn't get out of a chair. And he was admitted to hospital, and he had every test under the sun. And they couldn't find out what was wrong with him. And the GPs just said, look, you're old. So I did what all, I think, sensible doctors do and phoned a friend. So I got another colleague to see him, a care of the elderly doctor, who did, again, what all sensible doctors do, and went back to the beginning and looked through all of his medical records and found that one of the tests hadn't been properly interpreted. And in fact, Bramwell had a pituitary tumour in the middle of the brain, which had stopped the hormones being produced in his brain that maintained blood pressure. So whenever he stood up, his blood pressure was crashing into his boots. And he'd really just been, I think it's fair to say, written off. Now, my friend and colleague who saw him phoned up the endocrinologist, the hormone doctor at the hospital, who immediately phoned me and said, quickly, come and get some hydrocortisone, come and get some of this medicine. I said, well, I'll pick it up tomorrow morning. No, come down now and pick it up now for your father-in-law. So this was a Friday evening. So I whizzed down to the hospital and got the hormones for him and gave them to him. And thinking, well, I don't know. He's well into his 80s. I hope it makes some difference. Well, I gave them to Bramwell. And at 6 o'clock the next morning, there was a knock on our back door. And we all sort of crawled out of bed. And there was Bramwell, and he said, I'm back. It's a miracle. It can happen. And it was his hormone replacement that had been missed that had led him to that. Bramwell's now 95, so we're 10 years later. He's still going as strongly as a 95-year-old and still living at home independently. So these conditions are worth looking for, and it's incredibly rewarding finding them. And each of them individually is rare, but as an aggregate are not rare. And so what you'll see is that as we get older, we pick up lots of different problems. So we might have visual problems, we might have sensory problems in our feet and fingers, we might have joint replacements and muscle weakness, we might have lost our hearing, we might have weakness of inner ear balance function, we may be depressed, isolated and low with all of our symptoms. And all of those factors can work together to produce a multisensory balance disorder, a multisensory dizziness, lots of things contributing. And my life view is that if we try and identify each of the problems individually, we know we can't treat all of them, but if we can identify those ones we can treat, then we have a good chance of improving our patients' quality of life. So in summary, there are lots of problems that can cause balance that are not related to the ear. The older we get, the more of them might be working together. And if we can identify those particular problems, we have a good chance of making our patients safer and improving quality of life. Now, that was a pretty heavy talk for you, I know, for a Saturday afternoon, but I hope it's given you some insight into the way that I think as a doctor and how other doctors think when they try and identify what the cause of your balance problem is, and at least gives you some hope that there may be some conditions out there that we can treat to make your life better. So thank you for listening.
Thank you very much indeed.
Yeah,
Absolutely
very
brilliant.
yeah.
We're going to crack on because we've got lots of questions, and one question relating to something that's that you mentioned during your talk, and a lot of people are asking about it, including myself. Actually, you thought, well, that's one I've not heard before. I'm not sure if Kelly is available to see the questions in the chat. But it's all to do with the varifocals. You mentioned varifocals. Tell us a little bit more, if you can, Peter, about this. Are you suggesting that, you know, we shouldn't wear them at all, just wear them whilst we're having a dizzy spell or a migraine? You know, lots of people are hearing this for the first time.
Well, my guidance is if you have migraine, varifocals are not a good thing to wear anyway, full stop. And if you have episodic vertigo, if that's your problem, say it's Meniere's disease or BPPV, I think varifocals are fine. But if you have either migraine or a chronic balance disorder, in other words, you're unsteady, and you have a condition like PPPD, persistent postural perceptual dizziness, if you're worse in motion, scrolling on a TV screen, going into supermarkets, I don't think you should be wearing varifocals at all. Because what it's doing is it's giving the brain confused and conflicting visual sensory information, which is conflicting with what is already a damaged sensory input from the ears. And then that meets in the brain, and that conflict is the fundamental basis of dizziness and balance disorder in very many patients. So my guidance is, as a general rule, don't use them. If you've got visual sensitivity, use distance glasses and reading glasses. And the same goes with contact lenses.
Wow. Okay. I'm going to have to go back to the opticians. I think some of us are going to have to do that today.
What's interesting, I promise I wouldn't witter on, I know people, but what's interesting is opticians are beginning to learn about this. Some of them are aware of this.
Brilliant. Look, we've got loads of questions to get through. If you've got any others, try and put them in the chat. If we've got time at the end, we will come back to them. But I'm going to try and Tracy, some of the questions that we've had, and we're going to start off with a question from Tom. Tom's balance issues have worsened over around 5 years. He experiences lightheadedness when standing, difficulty walking, and frequent falls. He doesn't have vertigo or Meniere's. Suspected causes, he says, include peripheral neuropathy or central nervous system problems with a lumbar puncture pending. He feels drunk when standing and can't keep his balance, but is fine when sitting or lying down. Any thoughts on that, Peter?
Yeah, absolutely. I'm really sorry to hear that's where you're going. And the central part of my talk was on that range of conditions. So a peripheral neuropathy undoubtedly will contribute to that. But if they're looking at doing a lumbar puncture, they may be thinking about conditions like multiple sclerosis. And there are a range of, I don't know what age you are, but there are a range of conditions that come on in the 50s and 60s, which are what we term neurodegenerative conditions, progressive supranuclear palsy, multisystem atrophy, and a range of other conditions which can contribute to that. It may, in contrast, be slightly simpler. In other words, you might have the peripheral neuropathy plus a weakness of inner ear function, a vestibulopathy, or you could be having early Parkinson's disease. My point is that the essence of this talk is to say that there are a huge range of different conditions. And with your symptoms of progressive imbalance and falls, you need to be under the neurologist, who clearly you are. So you're in the right place to try and get your diagnosis. And I wish you really well with that.
Good luck with that, Tom. Georgina asks, I have vestibular migraine, and during pregnancy, her symptoms improved. She's heard that pregnancy can either improve, worsen, or leave symptoms unchanged. Do you think her past experience means the same will happen again, or is there still a chance that her symptoms could worsen or even stay the same, Peter?
Yes, and yes. I mean, what we generally find is that in early pregnancy, our ladies often find their migraine gets better. Where they struggle most is most commonly postpartum, so after delivery. And that's partly because of massive hormone shift there, but also because of the lack of sleep. So make sure your other half, one of the things I often say to my ladies is try and get some support at home, even if it's just 2 nights a week where you go and sleep in a separate bedroom and your other half looks after the baby, just to give you some downtime and recovery time. Those are sort of strategies just to employ. I mean, don't let it put you off having a family. It is unpredictable, as you've said, and I don't think it should influence your decision-making on having a family, and good luck with that as well.
Barbara is the next person asking a question today. In Meniere's disease, do grommets without steroids help improve symptoms like ear fullness? If so, will vertigo return when the grommet naturally comes out, Peter?
Okay, I'm going to let Kevin answer that one.
I can answer part one. I was having the most awful sensation of pressure in the head. And it's something you just cannot ignore when it's in your head. And it was cured immediately when I think it's piece called a T-tube was inserted. I can't answer part two because due to a certain surgeon's skill, that T-tube remains in place after about 10 years. So I have no idea what will happen when it falls out one day.
Well, I'm actually going to take you back a little longer than 10 years, Kevin, because Kevin has given me permission to discuss this. But before the T-tube, I put in a standard grommet, and they last on average 12 months. And at 12 months, you may not remember calling me and saying, it's definitely out. You've got to do something. All of the pressure come back. I don't know if you remember that. But so the
No,
answer to the question is
what's that?
yes, they can help fullness. Yes, they seem to be able to reduce dizziness. But there is a but. I can't give you a scientific paper to prove that. So there is some uncertainty in the science of it. But for patients with Meniere's and fullness in the ear, they do seem to help.
All right. Yasmin's question is about well, she says she has had labyrinthitis for 6 years with 90% hearing loss in her left ear. She takes medication daily and does the Cawthorne-Cooksey exercises twice a day. The exercises help manage the dizziness, but will it get worse as Catherine gets older? What more can Catherine do to feel better and regain some sort of normalcy?
Okay, so that's a good question. Again, labyrinthitis is very different to vestibular neuritis, and your description of having lost most of your hearing is very typical of labyrinthitis. It's slightly semantic, but you don't have labyrinthitis now. So labyrinthitis is a one-hit wonder. So you have it for a week or so as the viral infection or the micro stroke, whatever it was that caused the injury to the inner ear is active, and then you're left with vestibular hypofunction. So you're left with a balance disorder in that ear, reduced balance function. So the function will never recover. The first thing we need to do is just to make sure the diagnosis is right and to make sure nothing else is going on. So you don't have BPPD with it or any micro strokes, whatever else with it. And then push on with the exercise program. Now, if you're just doing simple Cooksey-Cawthorne exercises from a sheet, the success rate of that is pretty low. If you have a tailored vestibular physiotherapy program, so you see a dedicated vestibular physiotherapist or audiologist, you have a much higher likelihood of improvement. And overall, 85% of our patients will get very good improvement. But if you've had a really severe labyrinthine insult, you may be left with some symptoms which may fluctuate. But I would suggest to you that making sure that you've seen a really experienced vestibular physiotherapist and making sure the diagnosis is correct is really important. And you don't, if you're just using a simple paper sheet that you've been given, you need more input than that.
All right. Alexandra's question is about her having 27% nerve damage, right vestibulopathy. Despite 2 months of vestibular rehab, still feels dizzy, feels fuzzy-headed. How likely is it that Alexandra will have a full recovery?
Oh,
Is that a question I've already asked?
No. It's very different to the last question because the last lady had 6 years of dizziness with hearing loss from a labyrinthitis, which is severe. And this time we're at 2 months. So the answer to your question is it's very likely you will get recovery because on vestibular physiotherapy, it's often, our patients often feel worse by months 1 to 2. And it's usually month 3 that we begin to see some improvement, and maximal benefit normally develops over 12 to 18 months. So if you have a dedicated program of vestibular physiotherapy, you increase the physiotherapy you do with your physiotherapist or audiologist over a period of time, you're very likely to make an excellent recovery.
Keep at it. Keep at it. John says, my main issue is vestibular migraine triggered by eye strain and light quality, especially on overcast days. However, my symptoms improve during, the sunny weather. Is there a link between light quality and balance issues? And can anything mitigate symptoms during low light periods? John says he already uses daylight lamps and reduces screen time as well.
Yeah, that's a really common and a really good question. And it's this concept of migraine being the irritable brain. So migraine doesn't like certain types of sensory stimulation. And so some of the things our patients use are dark glasses, sunglasses when they're outside. Some people use blue filters on their screens. You can buy, if you're in a job, it's an occupational illness, so your employer is duty bound to make reasonable adaptations, which might include getting blue screens, putting you in a quieter office environment out of strip lighting, for example, because strip lighting is one of the things that really affects people. And if you go into the settings on your computer, most computer settings will allow you to adjust the settings. So for example, on my screen, I have day and night settings. So as the sun sets, my screen turns black and the words are white. And it's that sort of, so I don't get strong visual stimulation at night. And it's these sort of changes that you can make, which can really simply implemented and can make a big difference. So good question.
Simon says, I have vestibular migraine and Meniere's disease. Can you explain how these conditions are similar, how they differ, and why they are sometimes confused?
Are you sitting comfortably? I could spend all day talking to you about that, and it's a fabulous question. And thank you for asking it, because we spend a large amount of our life trying to work this out. Because what's going on here? Meniere's is an inner ear problem. Migraine is a brain problem. Yet, weirdly, migraine can present 10% of patients with migraine get spinning. 15, 20% of the population have migraine. By default, 2% of the population have vestibular migraine, so 2 in 100. Yet Meniere's is 1 in 1,000. So for every Meniere's patient I see 20 vestibular migraine. It's so complicated that we often say to patients, you have a migraine Meniere's overlap syndrome. To make it more complicated, 40% of my patients with Meniere's also have migraine. So I think the answer to your question, and we've scratched our heads and tried to work out what it is that's going on here, is that the symptoms of vestibular migraine and of Meniere's disease can be very, very similar. And here's a really worrying thought, well, not worrying, but challenging thought, that amongst the symptoms of vestibular migraine are tinnitus and low frequency hearing loss. Hang on a moment, I thought that was only Meniere's disease. Do you see the challenge? So I think it's that what's happening is the part of the brain that vestibular migraine is affecting is the same area that the ear symptoms of Meniere's disease are simulating. So really, really complex interaction, something we think and talk about all of the time, and sort of watch this space. But very, very good question.
Okay. Laura says, I get dizzy when lying on my back, which is required for cataract surgery. Could pupil dilating drops have triggered my viral labyrinthitis, which appeared after using them?
Okay, so no, the drops won't trigger a viral labyrinthitis. Stress can trigger vestibular neuronitis, so reactivation of viruses. The commonest dizzy syndrome that occurs after cataract surgery is BPPD. It's like being at the hairdresser's or the dentist, because you have to lie down till you head back a little bit. Just make sure it is labyrinthitis, pretty rare labyrinthitis. We had that questioner with it just a moment ago. But labyrinthitis implies you've lost your hearing, a significant amount of hearing, as well as balance. So it's pretty unlikely to be that. So the other the three possible explanations are firstly a coincidence, because 5% of the population get an inner ear dizziness every year, and it may just be a coincidence it happened around your cataract surgery. Secondly, it might have been caused by tilting your head back and it was actually BPPD, so make sure the diagnosis is correct. And thirdly, many viral conditions such as viral neuronitis can be triggered by stress, and if you're very stressed by the surgery, it could reactivate an underlying viral infection on the ear.
All right. This is Vimla's question. Vimla says, I've got vestibulopathy, right-sided high drops, and visual preference after cyberknife treatment for a benign meningioma. Hope I said that right. I struggle with fatigue, which makes it hard to do the vestibular exercises. My physiotherapist says low air pressure worsens my balance. Can anything besides exercise help with the balance, and are there any medications as well that could assist?
Okay, well, I mean, it slightly depends where the meningioma is. I'm assuming from your description it was a posterior fossa internal acoustic meatus meningioma. So in other words, I'm not asking you to give that diagnosis. So I'm just assuming that the cyberknife treatment was in the area of the inner ear balance organ. And if that's the case, that will have reduced balance function. It's the same as having an acoustic neuroma, vestibular schwannoma treated with the cyberknife. The cyberknife, for those who don't know, is external beam radiotherapy, which is focused from multiple different angles and zaps one tiny area of the brain. So it's a brilliant, brilliant therapy. The answer to your question is vestibular physiotherapy is the mainstay of treatment. And you really just have to push on with that. You can take some vestibular sedatives, things like sonarazine, Arlovert. Some of these medicines can be helpful, but I don't really encourage them because they slow adaptation. And it's very much about pacing yourself with vestibular physiotherapy, exercise, getting outside, just trying to stimulate as much as you can.
Ooh. More questions. don't forget, if we have time, we will definitely go to Kelly and get some of the questions that are coming in on the chat as well. So please bear with us. We've had quite a lot of questions today. Peter, you're an extremely popular man. We've got a question from Judy. I have vestibular migraine. I recently felt very dizzy while walking on a slightly moving pontoon and was unwell for hours afterwards. Do you have any advice for traveling by sea or air, as I'm afraid of being unwell but don't want to avoid travel?
Yeah, I mean, it's really unpleasant, isn't it? So motion intolerance is very common in migraine, and to some extent it is your lot. The advice I would give is as follows. If you're in certain environments, wearing a face mask, blindfold can be quite useful. So if you're say you're in a train or you're a passenger in a car, if you wear a blindfold, so you don't get the visual sensory stimulation. Even it's quite, if you're flying, for example, I always recommend, if you can afford to go into a business class lounge, go and sit in a quiet corner of a business class lounge, so you're not in the hubbub of the airport. Try and avoid the queues in the airport. When you're on the plane, put noise cancelling headphones on, maybe put a mask on your face so you don't have that stimulation. Avoid alcohol and caffeine. You can take travel sickness tablets. Cenarizine, Stugaron is the mainstay of treatment. But if you're going on a long haul flight and you're really dreading it, benzodiazepine, Valium, Mama's Little Helper from Mick Jagger, do you remember? Yeah, things like Valium, diazepam is actually really helpful because A, it'll let you sleep during the flight, and B, it is a vestibular sedative, so it suppresses the function of the balance organ. Look after yourself. So if there's going to be a period of jet lag, say you're going long haul, just have a rest period after you arrive, because you're going to find it much more difficult as a migraineur. Watch very carefully what you eat so you don't have any of the major triggers of migraine: red wine, alcohol, cheese, chocolate, citrus fruits, caffeine, that sort of stuff. So, and don't give up the holidays.
And Kevin's posted in the chat as well a link to how you can get the sunflower lanyard as well, so you can ask for help if you are traveling. And no doubt Kelly can talk a bit more about that as well at the end. No, an anonymous question. I'm struggling this afternoon. My apologies. An anonymous question now. After a frustratingly long journey to get diagnosed with a balance disorder, I now understand the importance of timely diagnosis. Could you advise on strategies or guidance we can provide to GPs and consultants to help speed up the diagnosis for those of us that are undiagnosed with balance conditions, particularly within the NHS?
Yeah, no, I think that's a really good question. It's almost unanswerable. 15, 20 years ago, I worked with the Department of Health, and really what I felt very strongly the right thing to do was, for each region, we used the term balance czar at that point. So we wanted each region to have a named expert in balance who could run a balance centre for dizziness and to lead the service locally. Now, we're lucky in Leicester that we have the Leicester Balance Clinic. We're unlucky in that we're utterly and completely overwhelmed. And if you think of the numbers, you'll understand the challenge. So we have a population of 1 million in Leicester. 5% of the population get ear-related dizziness a year. That's 50,000. We have a massive balance clinic in Leicester, but we can only manage 7,000 appointments a year. And that's having one of the biggest in the country. So the demand is just so overwhelming, it can't be satisfied in a way by the health services. We've tried pushing some of this out into the community, but unfortunately, the level of expertise as a general rule just hasn't satisfied the need. So my own belief, my own mission, the reason I run a 3-day balance course every year, which is always oversubscribed, is really to try and get colleagues from all of the regions of the country to set up their own balance centres where they can develop communities of experts: audiologists, physiotherapists, ENT surgeons, neurologists, cardiologists, care of the elderly, doctors, etc., who work together. And in Leicester, the group we set up was, I take full responsibility for the name, was called the Spin Doctors. And we would meet together, 15 of 20 of us, and lecture on each other's areas of expertise after hours, just in our own community time. And then go out for a meal together. And it's that networking of individuals, I think, is the way forward. But it's very much about getting individual entrepreneurs in each area, so medical entrepreneurs, if you like, to set those services up.
Great suggestion from Leonard as well. He says on the chat, I gave my GP the Life on the Level leaflet showing the interactive spectrum diagram. So maybe that's a good shout as well, promoting what we do. But yeah, a bit more understanding there. Claire's question: after gentamicin treatment, I developed vestibular symptoms later diagnosed as otoxicity. My doctors didn't initially consider this, even though I was retreated with IV gentamicin for another infection. Could gentamicin or other antibiotics cause vestibular damage? And should this possibility be recognized sooner by clinicians?
Wow, that's a great question. Really great. Now, just to be clear to everyone, this person has had intravenous gentamicin to treat what is probably a life-threatening condition, so sepsis in a joint or bowel or some such, not intratympanic, so not the injection into the ear to treat Meniere's disease, so very different. The problem is if you have it injected into a vein, a very small number of people will be toxic to it, will be sensitive to it, and you lose balance function in both ears. Now, there are two potential explanations for that. Firstly, is that the total dose of gentamicin was so high. When we look at what's called peak to trough, but actually it is the total dose of gentamicin was so high that it's caused damage to the ears, and that's terrible if it happens. The second is 1 in 1,000 people have a mitochondrial genetic deficit. It's a bit of a mouthful. So there's a little bit of genetic information that's passed on in the energy organ in the body. And if you have this genetic deficit, you're super sensitive to gentamicin. Now, there is a real conundrum here, because there is a blood test you can have before you have gentamicin to see if you're that 1 in 1,000 who is super sensitive to gentamicin. You shouldn't have it. The problem is it means testing 1,000 people before you find one person who's sensitive to it. Is that justifiable from a cost basis? And secondly, you need that treatment quickly, because if you've got life-threatening sepsis, you don't want delay while you get the test result until you have the treatment. So there is a dilemma here. There's no question this is a medical legal question as well. I'm sure it's been challenged in court already, and I'm sure I've been involved in some cases as well, looking at other people who have had this problem. So the really difficult answer to your question is, yes, it is possible to test for it to see if you're sensitive to gentamicin, but as a general rule, many people are not tested for it because they need the drug very quickly, and it's extremely rare to be sensitive to it, and you're very, very unlucky to have had this. But if you get bilateral vestibular failure, i.e. damage to both ears from gentamicin, it's a difficult situation to be in.
Thanks for that, Peter. Sandy says that she recently visited a friend's house in Delaware, and she felt fine except for one day where she felt fatigued. When she returned home, her vestibular migraine symptoms returned. She's asking, could something in my home be causing this, like radon or mold, even though tests haven't shown anything so far?
Okay, I mean, migraine has a very, very wide range of triggers. I'm not familiar with radon being a particular trigger. You could speculate the mold is significant. So, for example, if mold gives you an allergy and causes your nose to block up and you snore, so you get sleep apnea, that'll certainly worsen allergy. Travel and stress are very big triggers for migraine. So if you've had to travel a distance to see a friend, that journey on its own can trigger migraine. The thing about migraine is any life stressors can be a trigger, and so the answer is, I suppose, radon I don't think is an issue, but things like molds I suppose in theory could be, but it's just such a litany of different potential causes, it's very difficult to be specific.
Kate, my symptoms fluctuate daily. I rarely have 2 good days in a row, with nausea and imbalance worse on some days. Could this be due to differences in how I sleep? And I wake up early, but my balance can be off the chart. Could this affect the symptom stability?
So the answer to the first question is yes, sleep can cause it. The thing to think about, though, is if you're waking up early, that's a very common sign of anxiety and stress. So it might be that you need to reflect on the stressors in your life that might be making you wake up early. And also we come back again to sleep apnea. Are you snoring? 1-2% of the adult population have got sleep apnea. They stop breathing during the night, and that's a big worsener. It's a terrible word, isn't it? For making balance symptoms worse. So sleep is definitely an important factor.
All right. Another anonymous question. Is there a link between anxiety and worsening balance condition symptoms? I think you kind of touched on this earlier, or is this imagined by the patient? Could anxiety be increasing physical symptoms of balance conditions?
100%, yes.
Yeah. John, are there any updates on vestibular implants and how effective they are?
Yeah, okay, so I've just got back from Uppsala. That was before Italy. And we have something called British Society, which is the biggest balance meeting in the world. We have all of the specialists over there. And there are a couple of groups in the world who are now undertaking vestibular implants. And for those of you who don't know what a vestibular implant is, it's a surgical wire that goes into the balance organ, a bit like a cochlear implant for hearing loss. And it is used in bilateral vestibular failure. So classically, for the patient who has had gentamicin therapy and lost balance in both ears. And they are actually showing significant promise. It's been much, much more difficult than we expected. We thought it'd be much easier than cochlear implants. It's actually proving to be much more difficult than we expected. But humans have now been implanted. It's not available clinically. We don't have a service, well, there's no service anywhere in the world that's available clinically. We don't have a practice in the UK for this. But one of my colleagues and I in Leicester are very, very keen to take this forward when it becomes available. And we're keeping in close contact with the surgical team in Europe who are developing it. They're really, really super people, really super people. And if and when, I think it's, normally we say in medicine, everything's 10 years away. I generally don't think it's 10 years away. I think it's much sooner. And we're very excited about this.
Couple of more questions to go, and then hopefully we'll try and get some questions in from the chat. In your opinion, have treatment outcomes for vestibular migraine improved over the past decade? And do you expect further improvement in the next 10 years despite challenges in the NHS?
Oh, yeah, absolutely, massively. But the first thing is recognition. Now, for a condition that affects 2% of the population, it's extraordinary that it's only just entered into the International Headache Society classification of headaches. I mean, it's amazing that it's only been formally recognized in the last couple of decades. We're also doing lots and lots of studies on which drugs work for vestibular migraine as opposed to migraine itself, because all the drugs we use at the moment, things like amitriptyline, propranolol, topiramate, candesartan, and so on, are really migraine drugs that we're extrapolating and using for vestibular migraine. And one of the things we've found is that the triptan, sumatriptan, and so on, are really good for headaches, but they don't work very well for vestibular migraine. But what we've discovered is that there's a receptor called the CGRP receptor, which is on the blood vessels around the head. And this seems to be fundamental in the evolution of migraine and vestibular migraine. And getting CGRP antagonists, these are drugs you can have injected once a month, have been very effective in the management of vestibular migraine and reduce it by about 75% in studies that were presented in Uppsala last month. The problem is they cost about, I think they said it was £1,300 a shot. Now, in the States, that's not being funded at all because it's too expensive. In the UK, the NHS is funding it, but I can't remember what the numbers are, but you have to have something like 20 episodes every 30 days. It's something just so insane. You've got to be literally on death's door before they're willing to use it. I can't remember the exact numbers. But no, the NHS is actually funding it where the states aren't. But I think the answer to your question is our understanding of vestibular migraine is growing hugely. We've got lots and lots of research we're doing here in Leicester as well. And so I think there is real, genuine optimism on onward management. Yeah.
Brilliant, thank you. And we've got a question from Len as well. Bear with me. My balance symptoms of vertigo. This is sort of my balance symptoms of vertigo caused by vestibular neuritis are ameliorated following a meal, particularly in the evening. Could it be that more nutrients in the blood are helping the remaining nerves to function better? Is there any research on this?
I don't think so, no. I don't think that's going to be the case. I'm not sure the reason you feel better, but it's not going to be a nutrient issue. I don't think so, no.
Okay. I'm going to hand over.
Rupal, you asked me to be short and sweet.
Oh yeah, absolutely, because we've got a few more questions in there. I think, can we go back very briefly to the question about damp and mold? I think Sandy feels that her question wasn't perhaps answered properly.
We can do.
So, could it be something like damp and mold, like radon or mold?
Well, as I said, I don't think radon. I'm not aware of any association with radon, and I can't see how radon would cause an acute phenomena like migraine. Mold, could allergy trigger migraine? Well, I suppose, yeah. I mean, if anything that makes you feel unwell or stressed, as in a bodily stress, physiological stress, is a potential trigger for migraine. So if you have an allergy to mold, for example, absolutely, I see no reason why that shouldn't cause migraine. And then the second issue was about if you've got an allergy to mold that makes your snoring worse because it blocks your nose, for example, then that will also be a physiological stress. So that could potentially trigger migraine. Yeah. But the thing, what you have to remember is that in medicine, we don't know everything. I think it's, part of the theme of the talk here I was trying to show was that there are a myriad of different conditions which can cause dizziness, and it can be really difficult to get to that diagnosis. But within each individual condition, there are multiple potential triggers. And it's just impossible to do studies effectively to identify each sub-trigger. So, if you look at many of these, the study we did injecting steroids and gentamicin into the ear, it took 5 years to recruit patients, and the only variable was steroid or gentamicin, one variable. But if you think of migraine, there are thousands of potential variables that might cause or might trigger it. It's almost impossible to do studies to say, yep, that will, and no, that won't. We can only work on the basis of sort of educated guesses.
All right, I'm going to hand over to Kelly, because Kelly, I know there are quite a lot of questions in the chat.
Yeah, there are. So we'll dive straight in, Peter. I know we've touched a little bit on sleep and flying today, but Deb was asked a question about why is it that flying and lack of sleep can increase dizziness?
Well, it essentially, it depends which condition you've got, but they are stresses. So anything that causes a physiological stress, emotional stress, have an argument with the boss, whatever, will worsen dizziness. But physiological stress, biological stress, will worsen dizziness. And you can think of it in very simplistic terms, that when your body is under stress, it's on a state of hyperactivation, of heightened alertness because of that stress. And that amplifies the underlying balance disorder. So a lack of sleep, maybe scrolling on a screen, different lighting environments, having another illness, having a cold at that time, having the wrong food, being jet lagged, all of these stressors will worsen any balance condition. Yeah, I mean, that's really a universal experience. Yeah.
Thank you. Claire has asked, could loss of sensation in one foot when walking to be a migraine symptom or indicative of something else?
Yes and yes. So loss of sensation, there are a multitude of different causes. If it's in one foot, it's very different to the peripheral neuropathy that I talked about. So you would think firstly about a problem, say, in your back, so a disc in in the spine, trapping a nerve. Migraine can cause it. And then there are a whole range of neurological conditions which can be associated with numbness in one foot. And there are also vascular conditions if there's a blockage in an artery as well. So if you get numbness in one foot when you're walking, that's definitely something to talk to a doctor about.
Thank you. I think D. Ross has asked in the chat, so they've put been diagnosed with central vestibular disorder and also nystagmus and lack of smooth pursuit. Has great problem with depth perception, difficulty in telling where rough ground or curbs in front of me goes up and down. Has fallen, cannot walk outside or in unfamiliar places without testing the ground in front with a stick first. Because they've fallen in the past, how much of the problem is lack of confidence or anxiety?
Well, I mean, I can't quantify that, but some of it may be. But struggling on uneven ground, suggestive of maybe a peripheral neuropathy, so numbness in the feet. But the eye movement issues are a central balance disorder. So that's the coordination of the eye and the brain. That often gets worse with age, and there's a whole range of different causes. So there's undoubtedly an underlying medical cause here, and it will almost certainly be one of the conditions I discussed this afternoon. And in turn, you're absolutely right, that does affect your confidence. And so we get into that scenario that I explained, that you start to use the front of the brain, the conscious part of balance, rather than your reflex parts of balance. And that in turn stiffens your posture, increases your anxiety, reduces your balance, and increases your risk of fall. So yeah, I think it'll undoubtedly be a component.
So we've had a couple of questions in relating to COVID, so I'm going to kind of pull them together a little bit. Alison's asked in the chat, is COVID virus likely to increase balance disorder symptoms? And then we've had another question about the link between COVID and Meniere's. And again, can catching COVID then exacerbate symptoms of Meniere's and dizziness?
Okay.
What are your thoughts on that, Peter?
Okay, so I think I would take the word likely out. I don't think COVID is likely to cause a balance condition, but I'm very confident that COVID can cause a balance condition. So we've seen a very significant uptick in patients presenting with sudden sensory neural hearing loss, sudden nerve hearing loss, with acute tinnitus and with acute balance disorders after COVID. And I think that is a real phenomenon. I think I was certainly the only person in the UK who the Home Office gave permission to do autopsies on patients who died of COVID during the pandemic. And we were allowed to take samples out of the ear of patients who just died of COVID. It wasn't easy or pleasant, but we did. And we have a lab in the UK where we can grow the virus. So we actually grew COVID from within people. So we know that COVID can occur in the ear. That doesn't mean, of course, that that's the cause of a change in symptoms of dizziness, but we think there is an association. Many people speculate as to whether there's an association with COVID vaccine as well. That's been really, really difficult to prove. And the problem for that is the whole population had vaccinations almost, but 5% of the population get dizziness a year. So by default, 5% of people who've had a COVID vaccine will get dizziness. So do you see that there's real difficulty making the association? But I'm pretty confident that COVID itself can cause dizziness. And the association with Meniere's disease, I'm not aware that COVID can cause Meniere's disease. I haven't read anything on that. I've not seen any association myself. We think that viruses may trigger some people's Meniere's, so it's possible. And will it worsen Meniere's symptoms? For sure. Yeah. So anything that makes you feel worse, conditions like migraine and Meniere's disease are exacerbated by any other illness.
Thank you for that one. So another one in the chat then, we've got somebody's been diagnosed with PPPD and vestibular migraine, been prescribed propranolol, I think that's how you say it, for hyperstimulation and anxiety, because it might help with the PPPD. Is there anything else that you maybe could suggest?
Yeah, for sure. Yeah, that wouldn't be my first choice. Propranolol is good for anxiety, palpitations, and migraine, particularly in younger patients. In older patients, I tend to steer away from propranolol because it makes people tired. So if you're running a really busy job, you really don't want to be on propranolol because it just takes the edge off you. Now, my preferred medication in this setting would be an SNRI or SSRI. So that would be venlafaxine is an SNRI antidepressant, or citalopram or sertraline as an SSRI antidepressant. Now, we're not using an antidepressant here. That's not the aim of it. We're using its effect on the body in a different way. And they're really good for anxiety. That's what they're sort of manufactured for. But also they're the drugs that are best that we're aware of for PPPD. So I would prefer my patients to be on SSRI or SNRI rather than propranolol in that combination of symptoms.
Okay, just a couple more that I can see at the minute, so bear with me. So we've got a question from Ruth to say that apart from vestibular disorder, for which she's not been given a name, ENT don't want to know, but thankfully the physios and GPs have been amazing. She has peripheral neuropathy, and that's recently been diagnosed with a hereditary cause called HNPP. I'm not sure what that stands for. She's asked a neurologist if this might also be linked to my vestibular disorder, and he muttered possibly and wondered what he might think about that. So, what are your thoughts on that?
Yeah, I mean, I think it's reasonable for ENT not to feel they're the right people to manage this condition because it's a neurological condition. and the peripheral neuropathy is going to be a major cause of imbalance, and the management of that condition would be under neurology. I agree with that. Yeah, I'm not sure of the link.
Fabulous. And then the last one that I can see, and then Rupal, Kevin, if I've missed anything, please let me know. But it's from Lenny, and she's put if now it's another big word, prochlorperazine is discouraged for nausea. There we go. What is the alternative that could be used?
Yeah, okay, so prochlorperazine or Stemetil is a really good anti-nausea sickness medication and good for dizziness in the short term. As I mentioned in the talk, if you use it long term, a small number of people get Parkinson's syndrome, so it shakes and imbalance, and it actually makes the situation worse. And the second reason we discourage it is because it sort of turns off the balance system. It makes adaptation and recovery slower and worse as well. So in an ideal world, you would stop it, do your vestibular physiotherapy, work through the discomfort and get your balance back. That's the ideal. But what we can use are other medications that suppress balance perhaps slightly less aggressively. And some of the drugs we use are Arlovert, which has got sonarazine, another antihistamine in it, or cheaper, just sonarazine on its own is a drug that can be used. But just try and use really low doses of medication, because we don't really like you on them. And if I can just give you a very simple analogy to understand why. Imagine you're an aeroplane with a propeller on both sides, and you have a bird strike on one propeller, so it stops working. Well, if you don't do anything, the plane will sort of spin and burn out of control and crash or whatever. And that's like you taking to your bed and doing nothing with your balance problem. The second thing you can do is wrestle with the controls, and it judders all over the place and it's really difficult, but you change the flaps and the rudder. And then by adjusting to this new paradigm, you've got your balance. And that's what doing vestibular physiotherapy does. And the third thing you can do is you can turn off the other engine, and then the plane will glide. And that's what taking medicine does. It turns off the balance organ, you glide. But there's one small problem with that. I'll let you work that out. Yeah, so we discourage it.
Fabulous. Right, whilst we've been chatting, 2 extra little questions have popped in, so I'm going to just throw them at you, Peter, so just bear with me. But then that is, I promise we'll cut the chat from there. Rosie's asked should all ENT departments be able to offer treatments like steroid injections and grommets?
Oh, I think they do. They should certainly be able to. Well, that's a little bit unfair, actually, because we do have a pyramid of expertise in the UK. So we have district, there are some GPs who do, they're called GPs with special interest, who see balanced patients, and they're not going to be able to. There are some district hospitals where the doctors are not confident, don't see enough patients of that type, and they'll refer in. Any otology department, ear surgery department, will be able to offer this. And if your local group can't offer it, they should be able to refer in to a centre who can offer it. Yeah. So through the NHS, you should be able to get access. It might be slow. I mean, we have, we've done quite well in Leicester. We have, just to give you some numbers you might be interested in January of this year, we had 2,200 adults waiting over 65 weeks. So 65-week waits is the cutoff at the moment. And we had about 1,200 children in ENT in our department waiting over 65 weeks. We've worked really hard since January, and we've now got 10 adults and 10 children waiting over 65 weeks. So, we've brought the 65-week wait down. We are working through it. And it was just chaos after the pandemic. It's taken years to try and get things better. But so whilst you will be waiting, and if your department locally and you're in a small district general hospital can't offer it, that they will be able to refer you to someone who can.
Okay, last but no means least, we're looking for some inspirational advice to help Catherine go forward. So she has been diagnosed with vestibular migraine by the GP. The neurologist has said that there is no such thing and it's just chronic migraine. ENT has then told her that her dizziness is just caused by being a middle-aged woman and just needs to do Pilates and get out there. And as a result, as you can imagine, she's feeling quite discouraged. So...
Well, I'm really sorry to hear. That's very distressing. So I don't like that last comment at all. If someone's really said that to you, that's dreadful. I don't know what I can't believe that a neurologist would say there's no such thing as vestibular migraine. I mean, that's ridiculous, because there clearly is, and it's it's very, very, it affects 2% of the population. It's really, really common. Now, what they may be saying, and I hope this is what they were saying, is that you're in a really difficult situation with chronic migraine, and maybe the neurologist didn't feel you had a big vestibular component to it, and maybe the ENT was saying they think there's a big stress component to it. I think just reading between the lines, that's what they're trying to say to you. But the way that you've interpreted it, or the way that it's been put over to you, I just think it's really distressing, isn't it? And I'm really sorry that somehow that information has been put over to you. So chronic migraine it's horrible. You know, it's a really, really difficult condition. And it's really unpleasant for our patients who've got it, and it really ruins people's lives. And you know, migraine affects 10 to 15% of the population, so it's a massive problem. And vestibular migraine is a real phenomenon. There is no questioning of that. So that whatever you've been told, that is without doubt. And there are potential treatments for it. We talked about CGRP antagonists, and that's something that if you're getting migraines every day, and of course I can't say yes or no because I don't know your situation, but it's possible that something like CGRP antagonists, it's possible Botox injections. There's a whole range of treatments out there that might be suitable for you. And it sounds like just trying to find the right neurologist is what you should be looking for.
Fabulous. Thank you, Peter, for answering all of those extra questions as well today, as long as all the ones we did this afternoon. So, Kevin, I'm going to pass it back to you.
Super. Professor Rea, what can we say? You've done it again. Fabulous presentation. And I'm sure all the members today appreciate it. And thousands more will watch the video of this that'll be available from next week. You've demonstrated how many different routes there are to balance conditions, and why obviously it's extremely difficult for many clinicians to come up with accurate diagnosis unless they know everything you do. I'm drawn to one of the questions earlier of what advice do we have to GPs or consultants struggling to come up with a diagnosis. And what I'd say to all members is refer them to the recordings of June 2023, when Professor Rea gave a brilliant presentation, and to this recording, which will be available next week. So I think if a lot of GPs watch this, they'd get an insight into where perhaps they can help their patients go to get the answers. It is, I'm sure you're aware, Professor Rea, one of the most common issues we face from our members, which remember are all over the country and beyond the UK, is the difficulty in getting a timely and accurate diagnosis, which then, as all of you here today will understand, what comes part and parcel normally with a balance condition is heaps of anxiety, fear, depression, and it's just not helped at all when you feel you cannot access the treatment that you so crave. But thanks, Professor Rea, it's just been brilliant. It motivates me even more that even though there is such a myriad of ways in, most of us face such common problems with that loss of balance, whatever the diagnosis, whatever the cause. And together we can share help and advice on how to at least deal with that, and especially deal with anxiety. But brilliant. So thank you so much. I know myself and all the members just wish we could have you sort of appearing every month and run these online clinics, because as you can see, we broke all records today for attendance. We went over 70 individuals, and what you tell us is just wonderful, that we sadly struggle to access from anywhere else. So thank you very much for that.
Lovely to see you all. I'm just flicking through all the faces now, so nice to see you all. I recognise quite a number of you, so go on a fairly, well, actually sunny Saturday now. I may get some fresh air.
Yes, no, brilliant. One very boring little mention. We use a mass email system to email all the members now because we have over 350 people. If you may not be in attendance today if you've got an email ending at icloud.com, because for some reason our emails can't reach you. So that's why I'm mentioning it on this meeting recording, that if you're a member, you've missed the meeting, wonder why, and you watch this, if it's at icloud.com, you're not receiving our emails. What you can do if you watch this is contact me. I can receive your emails. And if you've got a second or different email address, we'll happily use that. And obviously, we try and solve the problem. Finally, make a note, 7th of December is our Christmas special meeting. We've got a panel of balance experts who, again, will be there to answer many, many questions. We will be covering areas of rehabilitation, anxiety as well as treatment. But thanks everyone for coming. Superb meeting. I am for once going to say to everyone, if you want to unmute, because we're going to say goodbye, now's the time to give Professor Rea a really big shout out and applause for everything he's done. So thanks everyone for coming.
Thank you.
Thank you, Professor Rea.
Thank you, Professor Rea.
Thank you so much.
Yeah,
That was amazing.
Well done.
See you all.
Thanks.
Thank
All
you.
right.
See you all
Have a
soon.
weekend, everyone.
Thank you very much. Thanks all.
Bye.
Thanks, Ruth and Kelly. Brilliant today. Bye-bye. Bye,
Bye.
everyone.